My name's David Hill. I'm a pediatric allergist and a physician scientist in the Division of Allergy and Immunology. It's my pleasure to speak with you today about our paper, soon to be published in Pediatrics, entitled Guidelines for Early Food Introduction and Patterns of Food Allergy. Food allergies, especially peanut allergy, are one of the leading causes of anaphylaxis in children, and they affect the quality of life, nutrition, and healthcare costs of 1 in 20 children. For many years, families were advised that they should delay introduction of allergenic foods like peanut. But landmark studies, such as the LEAP trial, showed that early introduction of peanut in infancy could dramatically reduce the risk of peanut allergy. In response, beginning in 2015, national and international guidelines shifted to recommend introducing allergenic foods around 6 months of age rather than delaying. The big question has been, however, are these new recommendations actually changing patterns of food allergy in clinical practice, outside of controlled clinical trials? Our team studied over 100,000 children from 2 large U.S. health systems using electronic health records. After the 2015 and 2017 early introduction guidelines, we saw significant declines in new diagnoses of peanut allergy, as well as overall anaphylactic food allergies in U.S. infants and children. For example, peanut allergy diagnoses dropped from about 0.8% of infants to 0.5%, and any food allergy diagnoses dropped from 1.5% to 1%. These declines were smaller than what the clinical trials showed. However, and importantly, they do show that the guidelines are having an impact on real-world practice. There's a few strategies that might help clinicians implement these guidelines. Firstly, we need to normalize early introduction. We need to encourage parents to introduce peanut, egg, and other common allergens around 6 months of age, alongside other solid foods. In addition, we need to keep it simple, reassuring families that in most cases testing isn't required prior to introduction. We need to educate caregivers by providing clear anticipatory guidance during well visits that highlight that regular, repeated exposure, a few times per week, is more important than large servings. Parents are more likely to follow through when the recommendations are direct and clear. In addition, we need to address barriers. Some families might be worried about reactions at home, and that's understandable. We need to discuss safe introduction strategies and when to seek medical help if concerns arise. Our current study showed declines in allergy diagnoses in infants, but many open questions remain. For example, which foods, doses, and frequencies of introduction are most protective? In addition, how do these practices vary by community or access to care? Finally, and importantly, we want to understand how sustained introduction actually contributes to protection. Ultimately, our goal is to refine recommendations so that clinicians have practical, evidence-based tools, and families have the support that they need to further reduce the burden of food allergy in the United States.